invite Professor V.P. Pandey from Indore to please chair the session and come on the dais.
So good morning to everyone. We are starting this morning session of paper presentation. Three presenters were supposed to come here for their platform presentation, but one of them is absent. So we have two, Dr. Darpan and Dr. Digvijay. Just stick to time. Your allotted time is 6 minutes, and we do have some marks for your timely presentation of important points, so that try to finish within 6 minutes, and after that there will be 4 minutes for question answers. Okay, so I invite the first presenter, Dr. Darpan Thakre, to present his paper on comparison of presentation of pediatric onset and adult onset Takayasu arthritis, a retrospective cohort study. Darpan to present.
The slides on a change. Okay. Good morning all. Today I will be presenting comparison of presentation of pediatric onset and adult onset Takayasu arthritis, a retrospective cohort study on behalf of our group. So pediatric onset Takayasu arthritis is the least common subset of Takayasu arthritis, and according to the meta-analysis which was conducted by our group, it accounts for total 1/5 of the patients with Takayasu arthritis. Till now, there are total only 7 studies which have compared pediatric onset and adult onset Takayasu arthritis patients, and the differences in the prognosis between these two subsets are still unclear. So in this study, we analyzed the presentation and prognosis of pediatric onset and adult onset Takayasu arthritis patients. So this was a single center retrospective cohort study, and it included 166 patients with Takayasu arthritis. Pediatric onset Takayasu arthritis was defined as less than or equal to 18 years of age as per 2008 July Press Printer classification criteria, and adult onset Takayasu were defined as per 1990 ACR criteria. Both these subsets were compared for presenting clinical features, angiographic subtypes, disease activity, treatment use, and mortality. Odds ratio with 95% confidence interval were calculated for all these variables. Waiver of written informed consent was obtained from the Institute Ethics Committee in view of retrospective review of the data. So out of total 166 patients, 47 were of pediatric onset Takayasu arthritis, which comprised of 28% of the total cohort. Majority of the patients were female. The mean age of onset was 14 years for pediatric onset and 30 years for the adult onset. The mean age of diagnosis was 18 years for pediatric onset and 33 years for the adult onset. There was no difference between the diagnostic delay and the length of follow between the two subsets. The proportion of the patient with comorbidities, although were higher in the adult onset Takayasu arthritis, but those were not statistically significant. Among the clinical features, stroke and TIA were commonly observed in adult onset Takayasu arthritis with p-value of 0.049, while arthralgia and heart failure were more frequently observed in the pediatric onset Takayasu arthritis. The baseline investigation and the disease activity as per ITAS 2010 and physician global assessment. Overall, CT angiography was the most common imaging modality used at the initial presentation in this cohort. However, there was no difference between the imaging modality used between the two subsets. Among the angiographic classification individual results, we found that bilateral renal involvement was more common in the pediatric onset Takayasu arthritis patient. And when we subdivide this patient into angiographic subtypes as per the HATA classification, there was no significant difference between the two subsets. The treatment modality used between the two subsets was similar. The proportion of the patient who underwent the procedure was similar between the pediatric onset and adult onset Takayasu arthritis patient. However, the major infection which either led into hospitalization or led into death were higher in the pediatric onset Takayasu arthritis patient. Overall, we observed 10 mortality in this cohort, out of which 6 were of pediatric onset Takayasu arthritis, out of which 2 were because of the heart failure, 1 is because of the sepsis, 1 is because of the stroke, 1 is because of the myocardial infarction, And for one patient, cause of death was unclear because that death was outpatient death. Among the adult onset type 2 arthritis, there were total 4 deaths. One because of the heart failure, one because of sepsis, one because of stroke, and one because of the myocardial infarction. The greater risk of mortality was observed in the pediatric onset type 2 arthritis with a risk ratio of 3.80. So what does our study add? So this is the meta-analysis of the 4 studies which was conducted by our group, which compared the mortality between the pediatric onset and adult onset type 2 arthritis. What we have observed over here is that the log risk ratio if you was 0.52 and with the confidence interval minus 0.46 to 1.49, which showed that it was not statistically significant. But when we added data from our study to this meta-analysis, what we observed is that the log risk ratio was 0.82 with the confidence interval of 0.05 to 1.58, which showed that it was statistically significant. And we calculated the pool risk ratio, which was 2.27 without difference in the heterogeneity between the studies. So our study showed that in the pediatric onset type 2 arthritis patient, heart failure, major infections, bilateral renal artery involvement, and mortality were higher. So to our knowledge, this is the first study which showed the greater risk of mortality in pediatric onset type 2 arthritis as compared to adult onset type 2 arthritis patients. And this greater risk of mortality was evident even after adding the data from our study to the previous meta-analysis of 4 studies, which didn't show any significant risk of mortality in the pediatric onset. So this is the first study which we know of in the world which showed the greater risk of mortality in the pediatric onset type 2 arthritis. Hence, clinicians should be more vigilant while managing this subset of pediatric arthritis owing to the greater risk of mortality in these patients. Thank you.
So, do we have any audience questions? You are the only audience. Any questions? I would first. What was the total duration of illness? Because in the mean duration of illness between those two.
The length of follow-up for pediatric onset was 31 months, and
31 months. So I can.
Yes.
So that's about 2.5 years. Cancerians can't understand in months. We need in years. So 2.5 years. And adults?
Adults of 51 months, so around 3.5 years.
So it was almost double. So did you see if there was a significant difference in that, if that came out to be?
There was no difference because we specifically looked for the diagnostic delay and the length of follow because those were the variables which are associated with the mortality which are showed in the other studies. So gender, this is duration, this is activity, comorbidity, these are all the factors which we look for so as to compare whether the risk of mortality is higher or less. So in between the two subsets, there was no difference between the diagnostic delay and the length of follow-up.
The other question was history of tuberculosis past. Did you look at that in either of them?
No, sir, we haven't looked at that.
So why am I asking? Do you know why I'm asking?
Yeah, because the arthritis has been known to be associated with the tuberculosis. One of the hypotheses which was presented by the Malaysian studies is that because of the underlying tuberculosis would have led to the lesser inflammation would have led to arthritis.
And the procedures you said, so what were those procedures?
The procedure was the arterial stenting. So
how many patients do you have the data? How many patients underwent stenting in both of them?
Yes, sir. So total 13 patients in the pediatric onset and 21 patients in the adult onset. So there was no significant differences between that.
And what is the mean follow-up of these patients?
So mean follow-up are around 4 years.
In both groups, it's almost similar?
3 years in the pediatric onset and 4 years in the adult onset.
And the outcome is what you've shown, mortality in about 4 days. And you said renal was the most common in... So is that what is seen in the other centers also?
Yes, sir. So what we extrapolated data from the meta-analysis is that the bilateral renal artery involvement is more common in pediatric onset, and the type 4 as per the HATA classification was more common in pediatric onset. While in adult onset, HATA type 1 is more common. So if we can go back to my presentation, so we had very 95 consonant interval of 1.02. So maybe if you had included more patients because we included biopsy, so if we have gone more than 200, we could have shown that difference in between the angiographic types. Because we had just justified it is a single center study. So and Takayasu is a very rare disease. So to have that 166 patient is also I think.
Do we have a damage index in Takayasu?
Sir, we calculated the damage index as well. This is actually we didn't find any.
Because you've shown the ITAS, which is the activity score.
I have showed the ITAS. We have also calculated we didn't show any difference between the diseases.
Okay, the last question is, if you get a fresh patient, is there a difference in the treatment that you would in between pediatric and... No, not in this, but if you get another patient, would you treat differently pediatric from adult, or you would treat the same?
I would be more vigilant by treating the patient because the risk of heart failure will be more, and mortality. So I would be more vigilant, and I would be one step forward to step up his immunosuppression and follow visit during like for pediatric
Pediatric is generally more aggressive in Sambidacha. Thank you.
Thank you, Iracon. For second presentation, I invite Dr. Digvijay Ekbute from Lucknow to present his findings of study of metabolic profile and common carotid intima media thickness in patients with psoriatic arthritis.
Good morning, everyone. I am presenting my study of metabolic profile and CIMT in patients with psoriatic arthritis. As all of us know, psoriatic arthritis has increased burden of cardiometabolic disorder, and there are various cross-sectional studies. One of the representative studies showed that PSA has higher metabolic syndrome than when compared to RA and ankylosing spondylitis. And chronic systemic inflammation is the driving force for this atherosclerosis and endothelial dysfunction. And CIMT is a validated tool for the assessment of subclinical atherosclerosis. So our aims of our study to study the metabolic profile and CIMT in patients with psoriatic arthritis. Objectives were the prevalence of clinical and laboratory profile, CIMT in psoriatic arthritis with its comparison with healthy controls, and we studied the correlation of disease activity with insulin resistance and CCIMT. This was general framework of the study. So we had 54 patients and 27 controls. Metabolic profile was assessed by NCP ATP3 criteria. CIMT was measured by BMOD USG. HOMA-IR, which is online calculator, which contains this fasting insulin and fasting blood sugar, and online calculators. We calculate the HOMA-IR. CPDI is an index which has it is a composite index comprising of peripheral arthritis, axial disease, skin psoriasis, dactylitis, and enteritis. And then by this SPSS version 16, we analyze the results. This is the thing about CPDI is it takes into consideration regarding this health associated quality of life, ASQOL, like patient reported outcomes also. In our study, metabolic syndrome was found to be in 19 patients, that is 35% patients, and these are the general mean values. Mean age was 37 years, and mean HOMA-IR was 3.31, and mean CIMT was 0.65. Mean CPDI was 6. So analysis of patients with metabolic syndrome, we have this CIMT which is increased in presence of metabolic syndrome, and in absence of metabolic syndrome it was 0.62, mean difference was 0.11, and the p-value was significant. Though the CPDI value did not achieve any statistical significance, but there was an interesting observation that presence of metabolic syndrome will have presence of dactylitis, and it was statistically significant. Analysis based on insulin resistance, CIMT was higher in patients who are having insulin resistance. Though the CPDI mean value was higher, it did not achieve statistical significance. And in sub-analysis like enthesitis, dactylitis, nail changes, they were not associated with any insulin resistance. Then the analysis based on CIMT was higher when compared to matched controls, and p-value was significant. And when the disease classified with mild, moderate and high grade, the p-value was not significant. And in general also, if you take right and mole classification and after take the CIMT, there was no difference found between all the subtypes of the PSA. The linear correlation analysis, correlation of CPDI with BMI or HOMA-IR, CIMT mean age was not significant, but HOMA-IR correlated well with CIMT mean total duration of illness, but correlation was not significant with CPDI and inflammatory markers. And CIMT mean correlated well with HOMA-IR and total duration of illness. And disease activity indices, it was not significant correlation. The conclusions drawn from our study was 35 patients had metabolic syndrome. 61% of the patients had increase in insulin resistance. Also presence of dactylitis was associated with metabolic syndrome in PSA, and patients with there was no association of disease severity with presence of metabolic syndrome, presence of insulin resistance. Though insulin resistance had higher mean CPDI value, the association was not statistically significant. First of all, the strengths we considered patients with metabolic syndrome, insulin resistance and CIMT. There are studies which considered only metabolic syndrome and CIMT. Some considered only CIMT. We took all the three variables, and CPDI as a composite index we had advantage, and the limitations where we could not take metabolic profile of the matched controls into the consideration, and it was a cross-sectional study design. Now we are continuing this study further, and I am just going forward with the lean metabolic syndrome, which neglects the central obesity criteria, and that's all. These are our images. Healthy control with CIMT of 0.45 and metabolic syndrome having this much, and this patient of PSA showing something. Thank you.
When you planned this study, what is the background information that you have? Because CIMT alteration is always done with all inflammatory disorders.
Yes, there are studies which had increase in CIMT in psoriatic arthritis in the international level, but there was no there was no studies on national platform which are in India which are performed, and we took all the three parameters in this. We not only took CIMT, we also took metabolic profile into consideration. We took HOMA-IR, insulin resistance into the consideration.
Audience, has any question? Yeah.
Amongst the patients as well as the healthy controls, did you look for statin use in any of those?
Yes, ma'am. I looked for. There were not using statins.
Okay, in both the. So did you exclude everybody
Yes.
that were on statin use?
CVD risk patients, they were excluded from the study.
Okay, okay.
Patients with known events, they were excluded.
Okay, thanks.
So in psoriatic arthritis, young onset psoriatic is more dependent on genetics, and older onset on metabolic parameters. So did you stratify according to the age? Like you've taken adult onset, but...
Yes, ma'am. Basically, my study had a conclusion that patients with metabolic syndrome were older in age. Their mean age with metabolic syndrome was something about 35. It was, and there were majority of the patients who had age of above 40. So around 52% of the patients had age above 40.
Okay.
No, sir, I have taken patients over 18
Oh, no,
years.
so this is adult. If I saw the tables correctly, your main activity score, wo jo index you have used, CPDI. We do DAPSA, so I am not. Was only 6 out of a total of a highest of 66, 68.
15.
15 is highest, okay.
Yes.
66 is the?
Tender joint count.
Okay.
tender and
Oh, no, that I know, Paru. I thought Upar. So then, indirectly, what is your inference from this? What you found is, you also found that it has no relation to
yeah,
activity.
mean CIMT values, sir, they did not have any association with the CPDI values. Though majority of the patients, if you take CPDI cutoffs, it was moderate disease activity. So that's what the conclusion.
Yeah, but what you're trying to say is that these patients, you cannot say that it is resulting from inflammation. Although, what is the mean follow-up of these patients? It's a cross-section study.
It is
Okay.
cross-section.
And did you include smoking and family history in your?
Yes. Sir.
Have you seen at that those parameters? How many were males?
Sir, males were 33 patients were male.
That is about more than half.
Yeah.
Smoking, there was no difference in smoking between these two groups.
There was difference.
No, between those who had a high CIMT and did you look at
Yes,
that?
sir, there was definite difference.
So then that could be one thing.
P-value was also significant. Even
And
in
family history?
family history of psoriatic arthritis.
Family history of hyperlipidemia or cholesterolemia or other things, diabetes.
I did not take that into.
Do you think that's important? Because
Yeah.
thank you.
Thanks, Digvijay. Both of you have presented your findings very well. So we can close the session now. Thank you very much.